Hello, everybody. We're going to give it just another minute or two, and then we'll get started.
Great. Good morning.
Okay, hello again. We're going to get started because we have a very full agenda. Very glad to see you all here. Thank you so much for joining us. As most of you know, we have since 2022 had a large public-private partnership that's worked together to help to address the many workforce challenges we have in health and human services. We've had literally hundreds of partner organizations and individuals that have participated in all sorts of activities. And these quarterly update meetings are a way that we can keep the many people involved aware on everything that's going on because there are so many workforce related activities in the state. And each time we meet, we try to highlight various activities so that you all know more about what's going on and also that we can hear from you. So as always, this will be a rather speedy agenda. The meeting will move fast. We have very full agenda, and I will remind and encourage our presenters to please do your best to stick to your allotted time. If you have questions or comments, please do feel free to put them into the chat. If time allows, we will respond during the meeting. If not, we will follow up afterwards as much as possible. And also, if time permits, we may today pose a couple of questions to you to get your thoughts on some important issues. So with that, we're going to dive right into the agenda. We're going to start with, so let me get my, we're going to start with a legislative update from Melissa, that will be presented by Melissa Campbell from the Rhode Island Health Center Association. She'll be speaking, providing an overview of the key healthcare workforce related issues that are currently under consideration at the General Assembly. So Melissa, take it away. Oops, Melissa, are you here? If not,
I see her in the line, Rick. It shows she's here. I don't know if her mic's not working.
oh. Okay, Melissa, we'll give you a moment, and if you're not able to be heard, we'll move ahead. Why don't we do that? I know Dr. Fisher is here. One of the legislative updates that Melissa was going to touch on was that there are a couple of bills that are in front of the General Assembly right now to address ways to try to enable foreign-trained health professionals, both physicians and oral health professionals, to work in Rhode Island. And to speak about that, we are very pleased to have with us today Dr. Stacy Fisher and Dr. Sam Zwetschgenbaum from the Department of Health. Dr. Fisher will kick things off by giving us an overview of RIDO's approach to the international physician licensing issues. So Dr. Fisher, please take it away.
Great, thanks so much, Rick. And if somebody can forward slides to mine, that would be really helpful.
Jump ahead now to, there we go. Oops, did it not? It's, uh-oh, why is it not advancing on the screen? Here we are.
Perfect. And these slides will be made available to you after the meeting so that you can get into more detail about these. But in general, for those of you that may not be aware, there are national requirements for practicing medicine, but there are also state requirements as well. And so I'll go through kind of the big picture really quickly, what currently exists in Rhode Island, and then go through a little bit about what this bill that's now been introduced in the House and in the Senate as well is all about. So first of all, keep in mind that the stages in a physician's career are really 4 years of medical school. There are a handful of schools that are now 3 years, but in general 4 years, after which you can call yourself a doctor. But you really can't go into practice. You need to do additional training, which is typically a residency. So primary care residencies are typically 3 years. More significant, I would say more complicated kind of specialties, particularly surgical specialties, can take 5 to 7 years. And once someone completes their residency, they can do a fellowship program and then apply for board certification. So in order to get a medical license, you need to pass 3 steps of what's called the U.S. Medical Licensing Examination, which is true in every state in the country. That's a national requirement. But board certification, when you think about your physician being board certified, is something that happens after they do their residency training here in the United States, and is realistically the gold standard for, say, infectious disease, which is the specialty I was trained in, or primary care as well. So next slide, please. There we go. So in order to become licensed to practice medicine in the United States, you need to graduate from medical school, complete training in a U.S. accredited residency program, and the group that does that is called ACGME. You have to pass all 3 steps of that U.S. medical licensing exam, or the USMLE, and then you need to meet the requirements for a license in the state in which you want to practice. It's important to know that every state has different requirements. There's some common themes that happen, and I'll go through what our requirements in Rhode Island are. It's important to know that already graduates of non-U.S. medical schools are eligible for U.S. residency positions. And so, Rick, if you want to click forward one more, that would be great. Oops, go back one. So in the match that happened just this year, nearly 25% of new residents were international medical grads. So a quarter of the people entering our residency programs in the U.S. are internationally trained in medical school. And for the most part, that was the way to obtain a license prior to 2022 when bills such as the legislation that's been proposed here in Rhode Island came into being. Now we'll go to the next slide.
All right.
So currently, if I'm an internationally trained physician, how can I become licensed in Rhode Island? Well, if you're a graduate of a non-US medical school or an international medical grad, IMGs is what they're frequently called, our requirements in Rhode Island are that you complete 2 years of progressive training in an accredited residency here in the United States, and you pass those 3 exams, as I spoke of. We actually allow 2 years of progressive training in a Canadian accredited residency program, and again, pass that exam to come in, which is true in every state. So currently, if you're someone who did medical school in another country, but has not done any of those 2 years of training here in the United States or Canada, you're allowed to come in if you are granted by the board that certifies your specialty, what's called advanced standing. So keeping me in mind, infectious disease, if the American Board of Internal Medicine that covers infectious disease said that I could come in, that I was eligible to sit for the boards and become certified, you would only need in Rhode Island to do 1 year of ACGME accredited residency or fellowship training. So we have a number of different pathways for people to get in already. And we have a special limited faculty license for those whose academic research appointments who have academic research appointments at, in our case, Brown's Medical School, so that unbelievably talented scholars who happen to have not done any residency training are able to get licensed as well. Click one more time, Rick. And what you'll see is that currently through all these pathways, we have more than 2,000 international medical grads that are licensed in Rhode Island, representing 20% of all of our physicians. So we already have a lot of international medical grads amongst our midst. Next slide. So one of the things that's important to know about this legislation and what's been passed across the country is really the notion of why do states like ours currently require that people do time in a US accredited residency program. And it's for a number of reasons. First of which, in order to have your programs accredited, you have to develop what's called graduated supervision. People come in as an intern right out of medical school that first week in July. They need a lot more supervision than they will 2-3 years later. So the notion that people that are trained to evaluate young doctors are able to be supervised in such a manner that by the time they're done, following something called the milestones, which is a standardized evaluation of clinical skills, the program director says this person is eligible for the boards and is good to practice independently. So they're judged by faculty members in the same specialty. Some of the things that have been observed with international medical graduates, both in the US and importantly in other countries, is that the medications, the equipment, the healthcare systems, the insurance, and the patient expectations are different in the US than other countries. So many of our international medical graduates that are in residency programs tell us that it can take 2 or 3 years to really get used to what it would be like to practice in the United States and in Rhode Island. Go to the next slide, please.
Oops.
So, oh, there we go.
Yeah.
Looks like some of them are missing. So I'll
Really?
talk. Yeah, that's okay. I can talk a little bit about the bill that has, I can do it. No problem. So the bills that have been introduced in the legislature are based upon legislation that was drafted by a group called the Cicero Institute. These have been passed now in 10 states. It's up for a vote here. Most importantly, it's important to know for everyone that there's not one single physician license that's yet been issued by any state that's involved in this kind of legislation. And a part of that is really because what this legislation does is it says that internationally trained physicians who've done a residency in another country or worked in a certain practice in another country can come in without having to do any US residency training. So that 1 or 2 years that we have in our statute would actually go to 0. So they wouldn't be required to do any residency training at all in the US. And what they do instead is say that a group that wants to train one of these physicians would agree to take them on. and essentially mentor them. So not supervised like in a residency program that has structure, and in the end you can become board eligible to take your board exams, but that they are essentially mentored and monitored and watched for a period of time. Our legislation would be a period of up to 5 years prior to being able to have a full license to practice medicine in that state. A few things that I've talked with my cohorts that run medical boards in the states where this is passed. It's been very difficult for those boards to really tell whether or not the training that an individual has had, say, in Qatar, is similar to the training that they would have if they were in the US based on their specialty, which has turned out to be the biggest burden. So RIDO has several suggestions for amendments to this, which we've submitted to the sponsors, which really would say, first of all, we can shorten the time period. And importantly, there's several international groups that are now accrediting residency programs. So we think there are ways to make this better with the notion of developing regulations that would, from our perspective, help to protect the physician as well. We don't want them to be taken advantage of if they come to our state through this program. So I'll stop there. There are some, as I said, there's some edits that are, or suggested amendments that are on the way from RIDO, and I will make sure that we get the entire slide set out to you so that you'll be able to see them all. And I'll stop there.
Thank you, Dr. Fisher, and our apologies for somehow omitting that last slide, but we will distribute it along with the full set of slides after the meeting. Thank you again. And now we're going to hear from Dr. Sam Zwetschgenbaum, the state's dental director at the Department of Health.
Great. Good morning, everybody. Pleased to be here as well. Just to actually, I'll compare and contrast with what Dr. Fisher shared. To be a dentist in Rhode Island and in the United States, you typically, actually keep that last slide.
Okay.
Sorry. In the United States, you essentially go 4 years to dental school, and in Rhode Island and in most states, it's required to graduate from a CODA, which is the Commission on Dental Accreditation, a CODA accredited dental school, either in the United States or Canada. Then you take board exams, and then you apply for a license. I'll say that there is a residency available for dentists to do. It's not required. There's only one state, New York, that requires a residency, but I did a residency. It was very formative. It was in a hospital, and I learned to work with medically complex patients. But essentially, when you go to dental school, you learn how to do everything, soup to nuts, so that when somebody graduates dental school, they have the qualifications to go into practice. When you do a residency, and Rhode Island does have a few residency programs, one at Samuel's Dental Clinic at Rhode Island Hospital, one at the VA, you get something called a limited license, which the residency director then attests that they will supervise you and go through various competencies. Okay, so that's just a background how dental licensure is. Dental education is different. Yeah, you could do a residency, but it's not required. Once you graduate, you're able to go on. Okay, so next slide. So I'm going to just present some information on dental professionals in the state. A slide that shows we have a lot of need for dental care, some disparities. Then I will talk about foreign trained dentists and an approach in Massachusetts. So next slide. Everybody who knows me knows that I have to show some data. I don't know why. But if you were to look at the data, you would see that in Rhode Island, we do have the lowest dentist to population ratio of all of the New England states, 52 dentists per 100,000 people, as compared to the US average of 55, I'm sorry, of 60, and Massachusetts with 80. And we have dropped a little bit since 2014 from about 55 to 52. Next slide. So again, lowest dentist to population ratio, but the other concern is, or not concern, is that there's just more teeth that need to be treated. It's not like in 1999 when 25% of people over 65 were missing all of their teeth. Older adults or people over 65 are keeping their teeth, and we have way more people older than 65. So that means there's a lot more dentistry to be done. And that map on the right, while I do share that 11.6, I can tell you that neighborhoods which are a darker purple, the rates are a lot higher, and as compared to those which is much lower. So we do have disparities in tooth loss. Next slide. And so what's the impact of having lower numbers of dentists is fewer of them will work with patients with Medicaid. It's much more difficult for people to get appointments. Our health centers often have challenges finding dentists to work there. And ultimately that leads to disparities in outcomes and disparities in access. And we have a lot more data at the Rhode Island Department of Health, but just as examples on the picture on the left, FRSM is free or reduced school meal programs. Higher free or reduced school meal is associated with lower socioeconomic status. And we can see that children that were examined were found to have higher rates of untreated tooth decay in lower socioeconomic status communities. So that's an outcome we should not be proud of. And on the right, we know that there are disparities in percentage of Rhode Island adults who had dental visits in the last 12 months, with higher rates of white reporting going to the dentist as compared to Black and Hispanic communities. Next slide.
Oddly, I don't see
Oh,
your
I'm
next slide
missing-
here either.
I'm missing my other slides as well. Well, if I could have, I have this on my desktop, and I'll just share that. Let's see. So what I wanted to share is that regarding foreign trained dentists is we know there are foreign trained dentists who are living in Rhode Island or want to live in Rhode Island, and many of them may be working as dental assistants or in non-dental fields. The plus is they have similar language and lived experience as Rhode Islanders who do experience disparities. But to become a dentist in Rhode Island, they would need to go back to school to do an advanced standing program. So many dental schools, including Tufts in Boston, NYU in New York, offer 2-year training programs. It's essentially 2 years of dental school for people with a limited, with a foreign trained license. And it's very competitive to get into these programs. My understanding, there's a total of 8,000 applicants for 650 positions per year. And as opposed to residency, they actually have to pay. So they pay about between $100,000 and $250,000 for their 2-year training. So somebody who wants to do these programs would have to apply, get admitted, and then pay a tuition.
Excuse me, Sam, I just need to ask you if you could wrap in about 1 minute, please.
Okay. So
Thank you.
what I wanted to share is that in Massachusetts, I think Massachusetts is one of the only states where they do offer a limited license similar to the residency license, where somebody can work under the direction of a dental director at a federally qualified health center. And they can be foreign trained without having to go back to school and work to get a limited license. The challenge to that is, again, similar to what Dr. Fisher was talking about, that we may not always know how their education was in their country. There is great variation among dental schools in the United States. So we know that legislation was submitted in this area, and I can share their significant concerns in the dental community in Rhode Island. But I do believe it's important to look at how is this working in Massachusetts and what can we pull from that that would help for future legislation and then obviously future regulations that would have to be developed by the dental board. So, and again, I'll make sure that you have all the slides.
Yes.
So
Yeah, there may be the problem may be on our end. Anyway, thank you so much, Dr. Zeshkamel and Dr. Fisher. Really appreciate those reports. We're going to switch gears now and have an update from one of our 3 Ladders to Licensure partners. For those who are not familiar with that, briefly, Ladders to Licensure is a new program that has enabled the state to support partnerships of higher education and employer provider organizations to enable unlicensed employees to return to higher education programs in pursuit of a health professional license. And we're going to hear now from Dan Tierney from William James College, which is leading one of those 3 partnerships. Dan.
Good afternoon, folks. Thank you so much, Rick, for the introduction. As you can see here on slide 20, this is an overview of our particular partnership, which seeks to stand up a career ladder focused on clinical mental health counseling. And I would be remiss, by the way, if I just don't extend a hearty appreciation and gratitude to Rick and Kristen, Ariana, all from the EOHHS team, as well as Jackie Restella, Sandy Gonzalez, and Brittany Huffman at our employer partners, who have just been excellent partners and I think, frankly, embody so much of what Ladders to Licensure is seeking to accomplish in bringing together educational institutions and employer partners to find creative solutions to workforce challenges. And we've been really appreciative of all the work across both the partners, but then also William James College as well, to come up with innovative solutions. So the problem is well known and I think well stated here. Rick, if you wouldn't mind going to the next slide.
Absolutely.
Two of the sort of the mandates from Ladders to Licensure is to create is to leverage tuition assistance funds to get folks back into school so that they may sort of get on that career ladder to ultimately achieve licensure. And to that end, William James College created opportunities for folks to come back as non-matriculated students in online courses that would ultimately count towards their clinical mental health counseling degree at the college, or frankly at any program that accepts it. And we're delighted to report that we have a cohort of students who started those classes I believe actually today. And the idea is that this will ultimately sort of allow folks to get a sense of how to balance school with their professional obligations and be sort of an introduction for those who maybe have been out of school for a time and are reintroducing themselves into higher education and deciding, whether they can sort of balance all their obligations. Rick, could you go to the next slide, please?
Yes.
So the second idea, or the second item that we're delivering on, is the creation of a career ladder. And for anyone who's worked in consulting, that sort of the first step in any engagement is you have to build the fact base, right? And so what we've been doing and creating is a overview, a schematic of the landscape. So an overview of how folks start as an associate or with an associate's degree rather at one of our employer partners and then make their way up through a career ladder to ultimately achieve licensure as a licensed mental health counselor at our employer agencies. And so what you see here is that we've created a career ladder or memorialized a career ladder with 6 rungs that articulates that journey from the bottom left-hand corner to the upper right-hand corner. And what I'll do now is I'll just showcase some of the nuance and the intention that we're trying to bring to this career ladder to articulate both the points of potential intervention, but also the complexity that you encounter when you try to make systemic change. So Rick, could you go to the next slide, please? So this is the sort of the base view of their career ladder. So you can see here that folks enter in with a pre-bachelor's degree. So we have folks starting with an associate's degree and then taking a job as, for example, a community health worker at an employer agency, and then finding and navigating their way up through, say, a case manager position, then ultimately achieving their bachelor's degree and rising up through the licensed clinical mental health or the licensed mental health counseling program. Next slide, please, Rick. The complication here, of course, is that there is an ecosystem that exists that's governed by statute, but then it's also governed by sort of by academic expectations as well around things like continuing education and all of the statutory requirements of those who are entering the licensure ecosystem. So that's one item to sort of overlay on this map. Next slide, please, Rick. And what you'll see here is what we tried to do is introduce various workforce support tactics that William James College has created, but then also that our employer partners have. So as an example, TIDES, our employer partner, has a well-articulated employer apprenticeship program for those folks who start as, say, community health workers, but then get upskilled to become, say, intake or intensive care coordinators, and have an associate's degree, but haven't yet achieved a bachelor's degree. So it allows them to rise up to rung number 2 without having gone back and got their bachelor's degree. William James College also has programs like the Behavioral Health Service Corps, which is effectively a Peace Corps for mental health, that tries to bring those who have achieved a bachelor's degree into the mental health care ecosystem by introducing them into careers in behavioral and mental health. So we've laid on these workforce support tactics in green. Next slide, please, Rick. But again, the challenge here, of course, is attrition. And so as part of building this ladder, one thing that we've tried to do is identify all the different pain points when folks might fall off the ladder, right? Folks might leave at rung 1 because for compensation issues, right? Or maybe because the schedules aren't flexible enough to accommodate either working the folks who are raising kids or taking care of elder parents. And we've also obviously found attrition points at places like rung 6 where folks leave after they've got licensure just because they're burned out. Or folks might attrit at rung 3 at the practicum level because there's not enough supervisory support for them, even though they are pursuing a master's degree in counseling, right? So we've tried to lay on that attrition to better articulate the pathway forward. Last slide, Rick. So then in closing, our next step here is to find ways in which we can price out the various workforce interventions that will solve these attrition points and just bolster and ultimately make the ladder that much more robust. So we are working now within our partnership to propose different types of solutions that would attack these pain points and ultimately just promote licensure within mental health counseling more broadly. So I'm grateful to Rick and team for all of their help as well.
Dan, thank you so much. Really appreciate it. And grateful to the work you and your partners are doing in all the Ladders to Licensure partnerships. And we will hear from the other partnerships at future quarterly meetings, by the way. Okay, now we're going to switch gears again and focus on a couple of quick updates related to our healthcare workforce data collection and sharing efforts. I'll just do the first one, which has to do with the Healthcare Workforce Data Dashboard, which hopefully many of you have already had the opportunity to look at. Perhaps if somebody can put the link in the chat, Ariana or Kristen, that'd be great for those who haven't seen it. The reason why we wanted to come back to this is because there's been some important additions made to the dashboard since our last meeting. In particular, we now have physician data, psychologist data, pharmacy data, midwives, physician assistants, and we also have additional information and tools to use in the dashboard, including we have a page specifically focused on advanced practice nurse specialties so that we can look at them by specialty. We have another dashboard page that's new, which is looking at the inflow and outflow of health professions by license on an annual basis. So how many newly licensed and how many are leaving the field. Also very important for our healthcare workforce planning and our health system planning. And finally, one of the things I want to highlight in terms of new data that will soon be coming into the dashboard is for the first time non-licensed personnel, and specifically certified workers who are certified by the Rhode Island Certification Board. We expect to be receiving data in the next few months about community health workers, peer recovery specialists, doulas, and alcohol and drug counselors, and a number of other occupations that are certified by the Rhode Island Certification Board. And that will enable us to know the same things about those workers as we know about our licensed workers, namely their total employment, the number of licensees, or in this case, certified folks, race, ethnicity, annual median earnings, and eventually career progression of folks in those certified occupations as well. So we're looking forward to sharing that with you in the future. I'm going to turn it over to Sandra Powell to give a quick update on the work that they are doing to expand data collection through the licensure system at the Department of Health. Sandra?
Hi, can you hear me?
Yes.
Can you hear me now? Okay, great. So thank you. So another run kind of on the data ladder really has to do with legislation that passed last June. It's called the Healthcare Workforce Data Collection Act. And this would add really information to what Rick has, already presented on in the dashboards that already exist. This legislation authorizes the Department of Health to collect healthcare workforce data on licensed professionals, healthcare professionals who are licensed through the Department of Health. So it's important because this is data that we don't currently collect, and the data collection would be part of licensure. The department has a system called EMLO, My Licensure Office. All professionals are either licensed initially or through a relicensure application, and the data collection would be voluntary, and that was something that was important, that was pointed out to us in terms of passing this legislation. So what are the data elements that would be collected? The first one has to do with specialty. We have professions, particularly we use physicians as an example. We have over 9,000 physicians licensed in Rhode Island. What are their exact specialties? And we think about it even in primary care as an example. We have pediatricians, we have internal medicine, we have family practitioners, we have geriatricians. So we want to get more data to understand the healthcare workforce. We also want demographic data. So race, which we collect today, and this would add to that, ethnicity. Very importantly is languages spoken other than English. We think about this in many domains, but behavioral health is a great one. If I were Spanish speaking and I were looking for and maybe English is not my first language, and I'm looking for a practitioner who I can communicate with in my language, this would be data that we want to collect through the licensure system. We don't collect today. Education level, and use nursing as an example. We have many, many nurses. Are they bachelor prepared? Are they master's prepared nurses, PhD prepared nurses? We're really trying to better understand the workforce. Another element would be additional years of practice. And this is about people planning to leave the workforce. It would be really important to understand if practitioners say, I'm going to be retiring the next 3 years, 5 years, 10 years, to understand both the inflows, we know by licensure, but the planned exits for the healthcare workforce. In addition, also practice status, the direct care that's provided, but also we have practitioners who are licensed, but they provide medical administrative care, or they do teaching or research or legal. So we want to understand what's happening. We have almost 20,000 plus nurses, but we could say everyone's not providing direct patient care. So again, we want to try to better understand the workforce, practice name or location. Sometimes clinicians work in multiple locations, again, to better understand what's happening with the workforce, Medicaid acceptance, who accepts Medicaid. And then finally, the law allows for other elements that RIDO can consider, which we haven't gotten there yet. And this work is being done. It's connected with healthcare planning, as Rick mentioned, and it's with the colleagues at the health department, the Office of Primary Care and Rural Health, the professional license team, and the data charter Center for Data and Analysis. It's a quick update.
Excellent. Thank you so much, Sandra.
Absolutely.
And now we are going to turn our attention to some funding updates. And this is always a hot topic, but perhaps more than ever, given some of the changes on the federal level. And to share with us some insights about the federal level and how the state of Rhode Island is tracking that, we have James Rajat from the Executive Office of Health and Human Services. James.
Great, thanks for having me. I'm just going to give a brief overview of how we are doing in monitoring the federal landscape that's changing and thinking about our contingency planning efforts across the EOHHS umbrella. Next slide. So many of you know that there are changes about, and those changes have the potential to interrupt, disrupt, or change the way that we are making progress towards our existing goals, while at the same time may require us to right-size our resource and our investments as we see a changing landscape. So the Executive Office of Health and Human Services is taking a targeted approach to understanding this and thinking about how we do contingency planning across our agencies. So the first thing that we're doing is we are tracking all of the federal policies that have been implemented and whether they are contested and a variety of other things, and understanding what level of disruption may occur from these policies moving forward. The second thing we are doing is working across our agencies to do a comprehensive review of the programs that we have as aligned to our mission, as aligned to how they are foundational to other programs, to understand those interdependencies, should things shift or should programs change. And then the last thing is we are brainstorming with community partners. What are some of the practical decision-making guidelines that we should be thinking about as these new policies are implemented and we see other decisions that need to be made, particularly around sustainability moving forward. And so these are the three areas that we are working across all 7 of our partners within the HHS umbrella to monitor. Next slide. So I just wanted to provide an example of what we're collecting. So when it comes to the policy tracking around what is existing changes that the federal government has proposed, you'll see here a variety of the data elements that we are collecting. And then for that specifically, when we think about how severe the impact might be, we are looking at population health impact. Is it an impact specifically on a subpopulation or a program? What's the economic impact to the state? What's our budget impact? What's the administrative impact? Does it affect our authority that we have as a state, and what our future plans were? So we are doing that to come up with scoring around these policy changes. When we look at our programs, we're looking at how well do they align to our mission? Is it a mandate? Is it a core area of our statutory authority? Is it a key foundational recommendation that we've made? What's the scope? How are the outcomes looking? And is it a foundational system that if we were to change that or to sunset that, it would affect a variety of other programs? So these are the types of information that we are currently just collecting around federal policies and some of our existing programs so that we can understand and navigate the landscape. Next slide. And so we are also looking at, well, what has been out there so far as it relates to the workforce sector and as it relates to the efforts of all of you on this call. And so here are the items that we've identified so far. Please feel free to let Ariana and Rick know if there are others that we're missing. But when it comes to labor markets, we're seeing things challenging around collective bargaining, contracted work, and minimum wages, and higher ed, challenges or changes to potential apprenticeship models, loan forgiveness or financial assistance, as well as job training programs. In terms of provision of services, we're seeing things that might impact workforce capacity and other shortages further. Certainly direct care pipeline changes, and certainly continued discussion about Medicaid cuts and those implications. And then there are some other impacts that were discussed earlier today and that relate to these things: immigration and citizenship policies, health and safety protections, particularly potential rollbacks, and the diminished ability to have labor management forums. So these are the items that we think are related to the work that you all are doing, that we are currently monitoring. And again, just wanted to provide that overview so you knew that we are doing this, but also feel free to let us know if there's things we're missing. Next slide. Great, thank you.
Thank you, James. That's a lot in a short time. Really appreciate it. Next up is from the Rhode Island Department of Education is Jake Jakowski, who's going to talk to us about their healthcare-related career and tech education programs.
Thank you. Yes. So my name is Jake Jakowski. I am a career and technical education specialist at the Rhode Island Department of Education. Thank you to the EOHHS team for having me here. Really excited to go over some of the new funding that we have for what we termed CTE for All grants that went out. So it is a grant that is designed to increase student access to high skill, high demand, high growth jobs. There were $2 million to support the development of new programs that are unique innovation areas that we do not have pre-existing programs or pathways for students that are RIDE approved. Altogether, we received 16 applications totaling over $5.7 million across 11 different career clusters. We ended up allocating $2 million of that, $550,000 was allocated towards specifically health related fields and across 9 LEAs. So next slide, please. Just a brief overview. We do have a lot of healthcare related CTE programs already in existence across the state in each of the different transportation regions through the state, clustered around Providence and Central Falls, Pawtucket area, but throughout the state. So just a brief overview of the lay of the land as it exists. We have some other new programs that are coming online, and I'll go into those programs right now very briefly. So next slide, please. So the first grant that we awarded was for Central Falls. This is an interpretation and translation program that is focused on students gaining skills to be a translator or interpreter in the medical, education, business, social service, or legal fields, with an emphasis on the medical and social service / legal fields. And we know that some of the conversations and efforts from folks that are on this call now were led to the application being focused on medical translation services and support. So thank you very much for all of that hard work there. And we anticipate that this will impact around 100 students in Central Falls. Next slide. So the next CTE for All grant that's coming online is at JSEC in Providence. The program area is for MRI / CT technician. We anticipate that this will impact around 75 students, but it will be rotated around so that the entirety of the Juanita Sanchez Educational Complex students have access to dabble in these programs, and so that'll impact the entire school of around 700 students to help fill that workforce gap for MRI techs. And next slide. And last but not least, we have a planning grant for a consortium of 13 LEAs, school districts across Rhode Island. This is a planning grant to develop and create 2 new program areas, radiology and respiratory therapy, to be implemented at the career and technical education regional centers and hubs. And so Cranston is accepting the planning grant on behalf of the consortium of interested school districts, and they've already established some pretty strong partnerships with industry, and we are looking forward to the proposed pathway that they come up with after this planning grant is complete. So these are some of the healthcare related CTE for All grant awardees that these programs should be coming online to produce standards in 2026, and then after that, those programs will go into effect. So beyond 3 or 4 years after that, to see folks actually enter the field with these credentials and with these pathways under their belt. So, just a brief update there. Thank you again so much, and as always, RIDE's appreciative of industry engagement and investment in the K-12 space, particularly in CTE. And so please feel free to contact me if you have any questions.
Perfect. Thank you so much, Jake. Really appreciate that. And now we will turn our attention to another new program that the state has launched just recently. And to hear about that, the Primary Care Training Sites program is Manny Ortiz from the Rhode Island Department of Health.
Hello, everyone. Hope everyone can hear me. And good afternoon to all. So happy to present a little bit about Primary Care Training Sites. It's a new program that just was authorized the last legislative session. And the goal of the program is really to advance primary care training. And we're talking about our medical students, our residents, nurse practitioners, and primary care physicians. When they're in school, they have to find places where they can train and become doctors. And sometimes it's difficult to place them. And so it happens, these placements happen in our primary care office where you and I go see our doctors. And so we wanted to take an opportunity to really expand that capacity, because that is one of the ways that we can grow our workforce. And truly, this is a program that was done in partnership with the community, CTC, or the Care Transformation Collaborative for Rhode Island, and others really kind of advocated in the legislative session to put this together. And as part of that is also taking into account the training that is being done and introducing them to the patient-centered medical home model, which involves not just our primary care doctor, but also all the other services that we need in order to be a healthy individual, right? We need mental health, we need to learn how to work with pharmacists, we need to learn how to work with all other individual disciplines that work in the primary care setting. And so this was really the goal of this program. And we had our application. You go to the next slide, Rick. We just had our application in March, and it just closed on April 19. We are actually last week just sent out awards to 34 sites. We're giving out in funding about a little over $2 million. And what we've seen so far is that this incentive program actually really works. We've seen a growth in just a projected enrollment. We're doing the application. We asked sites, how many students in the last year were you normally training? And based on this grant that we are going to give you, what's your anticipated capacity? How can you fund, increase your training? And what we saw is that overall 72% increase in overall training capacity, just from rough marks, about 400 students to 700 students. It's a big jump. And a lot of the increase were in our physician assistants that had the most growth, followed by our medical residents, nurse practitioners, and then obviously our students are still in medical school, about 45% growth. A little bit about the practices. We had some that are hospital affiliated, some that are in the nonprofit sector, some that are in the for-profit sector. We anticipate that all the training and all the learning collaboratives are going to begin in July of this year, and just very excited to get this going, because this is a key initiative for us as a Department of Health, but also with the community, to really work with the community to increase our training capacity. Currently, we're working with the sites to obviously finalize contracts and kind of move them through that process, all starting on July 1. And then for the preceptors, there's going to be a little program for them where we're not just letting them, we're going to be supporting them as they teach through learning collaboratives as part of the program. So that's my quick update. Rick, I'll turn it back over to you.
Thanks so much, Manny. Appreciate it. Next, we're going to hear from the Rhode Island Foundation, who will speak about the responses of one of our major philanthropic organizations in the state. Zach Nider. Sorry, Zach, welcome to you.
No problem. Thanks, Rick. So yes, I want to spend just a couple of minutes talking about some of the ways that we are, the foundation, thinking about supporting nonprofits, obviously, who are subject or are impacted by recent federal actions that threaten that funding. So I want to talk about three programs or three investments. One is we are supporting, and this is probably the newest one, we are supporting the Rhode Island Lawyers Committee Nonprofit Legal Protection Project, the NLPP. So this is an initiative that is coordinating volunteer attorneys to assist nonprofits in responding to federal actions. And through this program, nonprofits can receive technical assistance, guidance, legal assistance, as long as, sort of the qualifying factor being sort of organizations have been placed at risk due to federal executive actions, policy changes, funding freezes, threats, reductions, eliminations, contract terminations, or any other administrative delays. And nonprofits will have the opportunity to connect with a range of legal resources, including legal consultations, office hours, workshops, collaboration with national law firms specializing in federal grant programs. There's more information about these programs on our website. There's actually an intake form that you can fill out, but also there will be, and I'll put this link in the chat right after I'm done talking, there is going to be information session at the foundation on Wednesday. So I will put that information there. There's a registration link. I just want to be clear, if for any reason you cannot attend that, we understand. It in no way limits your ability to access these services. It's just we wanted to make sure there was at least one large-scale public information session about the program. And then just wanted to flag two other things, which we actually announced about a month ago as well. One is that through our core grant programs, our community priority and our capacity grant programs, we are earmarking around $2 million to target organizations impacted by federal cuts or freezes. That means that we'll be targeting that through the current round of those grants, which are being reviewed now, but also for nonprofits that are interested, the round of grants the applications will open on August 1st. So that it impacts both rounds of those programs in 2025. And then last, many of you may be aware, we also have stood up the Community Partner Resilience Fund, which targets organizations facing potential significant and long-term federal funding. So this is new money, and we've been targeting that funding towards scenario planning, financial planning, crisis communication, development consulting, and other supportive professional services. And again, more information about that program is on our website as well. And I'll stop there, but I will drop the link about the NLPP information session in the chat now. Thanks, Rick.
Beautiful. Thank you so much, Zach. And last but definitely not least, Jess Mayernick from the Department of Labor and Training is Program Director for Real Jobs Rhode Island with an update.
Hi, everyone. My name is Jessica Mayernick, and I'm just getting a little bit about Real Jobs Rhode Island and our current funding situation. We're currently in the process of reviewing some proposals. We did send out, I'm going to go back a little bit. In December of last year, we did send out a letter to all of our current Real Jobs partnerships that we were going to be, we will not be, entering to many new contracts starting January 1st of this year. We said, because of our funding situation around, some of our federal funds that have kind of either been depleted, most of them depleted at that point. A lot of our programs are coming to a close, our federal grants, and the ARPA dollars being fully spent down. We're not in the funding situation to approve, a program from each one of our, 60 partnerships. So we communicated that early. And then we have partners, we said, we'll check back with you in the spring when we understand where our funding situation is moving forward. This is in March, we sent out a letter saying, come in for ending April 30th, come in for funding from July to December of this year, not going past, because we are going to be not going to be extending award agreements for our current Real Jobs Rhode Island partnerships, which is the overall arching agreement for a partnership that makes them a Real Job partnership that they, responded to a solicitation in a past year. This also gets all of our partners on the same funding cycle, which right now we have a couple, 2 different funding cycles that people are on. So this gets them on the same process, and we are also going to be releasing a new solicitation asking partners to come in for that solicitation. I'll get to that in a second. So for the current funding proposals that have been coming in, we call them pitches. They were due April 30th, and we received about a little over $12 million in overall proposals. We do not have that much funding for the next 6 months to fund those, but it was a good place to start. People did understand that we are trying to kind of right size the program in a way where we were, we had a lot of pandemic money for the last 5 years, and now we're kind of looking at what does the funding situation look like for Real Jobs right now in a typical year that doesn't have those like pandemic relief funds, and we don't foresee necessarily a lot of federal funding coming down. So what can we do with our state funds and some very specific other funding sources that we have? So we did receive 1.3 million healthcare proposals. So from that, we have not made the official final decisions yet. Those are pending with the director at the moment, and we've been meeting with him over the last 2 weeks. And this was a really tight turnaround because we want to make sure we get money out the door as fast as we can for this. And this is all these contracts are expected to start July 1st and end December 31st. So my team is working really hard to get this through because we need to get everything out the door and up to, DOA as soon as possible with all the changes happening at the state level. So for the Real Jobs Rhode Island solicitation, we are going to be releasing that in this summer, probably end of June, early July. There are going to be some changes. So we discussed that in the letter that we sent out, that we are going to be aligning Real Jobs a little bit closer to the governor's Road to Prosperity work. And that's including, having programming, have work-based learning components, collaboration between partners, and defined career pathways. This is, something that Real Jobs really already cares about. We see best practices as best practice that when programs do have these work-based learning components and things like that. So just, aligning a little bit closer to the Road to Prosperity goals of this administration. But that's basically it. I don't know if anyone has any questions or.
Thank you, Jess, very much. Yeah, we are just about at time.
Great.
So thank you all the presenters, all the attendees. Really appreciate it. I know we squeeze a whole lot into these meetings. I hope you find it worthwhile. We try to balance the content and people's time constraints. So thank you again to everyone for presenting and for being here. And we look forward to seeing you next time.
Thanks.
Thank you.
Take care. Thanks.